then the thumb of my right hand can now go into the joint space in between the two bones, the radius and the ulna. And what I'm doing then is I'm squeezing all of those ligaments into inhibition, rather like the retinaculum on the elbow. So I'm squeezing them so that they're no longer pulling asymmetrically at rest. They've all got a pressure on, they've all got a signal, same signal, so it says, okay, so now I can free the joint off. So I want to take the joint into extension and flexion. I'll take the joint into extension and flexion, and I'll be able to rotate the arm inwards and outwards. And so I'm working the joint while I've got the inhibition on those ligaments. And that clears most of those kind of problems. Also coming down through there, you've got the nerves. That's the nerves. I don't know, a while ago, I lost my arm. Okay. And so what you've got coming down the inside of the arm is the nerves here, and also coming through the elbow here, and on the lateral aspect of the arm, you've also got nerves here. So as you're opening this joint up, and so you like this, my fingers around the joint, I want to extend, flex, internally rotate, externally rotate. Then I can glide further up, so I'm coming to the back of the arm to check if there's any tension at the back of the triceps. I've got tension at the bicipital tendon. I can then come up with the coracoid process and start to inhibit further up as well. So is there anything else I want to tell you about that? Oh, the interosseous tissue, yes, is what we're working here, is the interosseous tissue that crisscrosses in between these two bones, that, as we know, are going into internal and external rotation. So I'm gliding up there because that's where your channels are running, that's where your nerves are running, down through those channels there. So they need to be opened up properly. Because again, little problems in there, the same as the peroneus. If that's tense in there, it's going to cause a lot of problems in both the elbow, shoulder, and or the wrist. So as I'm working there, I've worked through the wrist bones, the carpal bones. I'm now working up the interosseous tissue, looking for anything that's still going to cause a problem. So as I get up towards the elbow, you start to look at large intestine 11, which is a big troubleshooter. But I'm also looking at the tension anywhere along that line to take it out, because I want that to work properly. I've now got the elbow working properly. So now I can put the elbow under my arm and I can go further up. And where I want to go further up is I want to be looking at the coracoid brachialis tendon, the pectoralis minor tendon, the short head of the biceps tendon, all originating on that coracoid process. Because if they're pulling forwards, the scapulothoracic joint of the scapula is also being tilted forwards. And that again is going to cause massive problems to my shoulder, not being able to move properly. And yet the muscles might test okay. You've got to look for tensions in there that could cause those restrictions to be able to get down onto the clavicle and come to the sternoclavicular joint. Anything else there, Jill?
I'm just looking. I found the case study sheets. No, yeah. No, you're just doing the ligaments. And
so if I put Paul back on the couch, what we found earlier was a restriction to that joint. So we jump you back on, Paul? No, I'll finish that off as a protocol.
Yes.
This side's not going to be as visual, so I'll talk it through and maybe do it from the other side as well. But basically what we're looking at is, while we had the hand, I'm separating the thumb and the finger, I'm working on the carpal bones, and I'm taking them through their flexion and extension properties with inhibition on the retinaculum. So I've got a vector going into there, vector going into there. I start at the medial border, and I'm moving each bone up and down inside that retinaculum to see if they can freely move. If I get one that's restricted, I simply pull the finger and the thumb apart and point the vectors to that nodal point. Then take it, glide it through its flexion extension properties, its condyloid properties, and free it out. So you're going all the way through. I would then return to any opponent's pili test that may be tested weak. That should now be testing strong. I've got no scratch test, so I've got no nerve aberration. So now I'm working my way up the interosseous tissue, which is the forearm muscles, of course. And as you come up to the top, the forearm muscles have synovial sacs. So that's why we get tendinous synovitis, which is basically golfer's elbow and tennis elbow. So when we come to here, you've got those sacs. Now, as a masseur, we were taught to work that in a cross-pattern friction for up to about 20 minutes. And that's what I used to do years and years and years ago. And it was always a problem with people who have fine hairs, the distance between putting some oil on or some lubricant and not friction in the skin. But also, if you did it wrong, then some of the hair follicles would mess up and they'd come back in with all spots on their arm. And it was like, there's got to be a better way to do this. So I don't cross-pattern fibre anything anymore. What I'll do is I'll go to large intestine 11, which is the biggest point in there. Just happens to be large intestine 11, and work the point. So I'm on the point, working the point, or I can come hand underneath, take it that way and milk it that way. And that's good for inflammations anyway, but if you've got an inflammation that's local, that's going to free that off. Then I've got the arm under mine. I've gone onto the elbow ligaments as before. I've got the medial ligaments here in this hand. I've got the lateral ligaments in that hand, which leaves me in the middle of the joint for my thumbs. I've got the radius, this bone here. I've got the ulna here, so I can work that joint and flex it and extend it. Also, the bicep tendon comes down to here. The brachioradialis comes down. The coracobrachialis comes down. The brachial radialis comes off it. So I can work those points. Now I've got a finger, and I can go up to the bicipital tendon where it joins onto the coracoid process, and I can see if there's any lengthening there, and can I displace it so I can move that area there. Then I can come under the axilla, and I'm pointing onto the anterior serratus with my thumbs or my fingers, with this still intact under here, so I can use the other arm. And I'm checking, which is what brought us to where we were looking, as to how the rib cage is displacing all the way down and come all the way down to rib 10. And all of those ribs, when I'm putting a general pressure on with one hand and the finger pressure on the interosseous ribs, I'm checking that each of those ribs move, because I want the whole of that rib cage to be able to expand in that 3 dimensions. Then I can come right up to the top here, and I'm under the axilla, and I'm pointing to the back of the scapula. So I'm under here and I'm pointing to there, which is pretty much you're going to get the tendon of the subscapularis, and a little bit lower down you're going to get the tendon of the triceps at the back and the tendon of the latissimus dorsi also. So you've got access to the tendons as they come off the thorax and attach to the arm. So again, I can feel for tensions there. So I'm putting a linear pull. Are they working okay? Is that working okay? That working okay? And that would also fit with some of the muscle tests if they were too tight or aerobic. I'm working that. So now I can squeeze the ligaments, and I'm on the piriformis. I'm on the, stop me and by one. I'm on the subscapularis tendon. And if I've got a tension there, I can now squeeze the coracoid, the conoid, and the trapezoid, and the acromioclavicular and the glenoid ligaments as a whole, inhibit those, and then stretch that muscle out from its tendon. Now, while I've still got that same grip on those ligaments there, so I'm below the clavicle, above the clavicle on the acromioclavicular joint, I'm on the humeral joint, I can now get the pectoralis minor and stretch that away from that inhibition. So if that was tight, so I could test that for tightness, which we could muscle test it firstly. And then how do you do the pec minor? Straight up, and then bring it back up. Press again. He hasn't got a problem, but I can use the inhibition on those points. Next one. Use the inhibition on those points to then allow the muscles to free off. So I can free the subclavius off from that inhibition. I can free off the pectoralis minor with that inhibition. I can free off the coracobrachialis. I can free off the biceps, and I can free off the latissimus dorsi tendon as it comes under the back of the arm. I can free off the subscapularis as it goes to the humeral here. And so I can free a lot of things off while I've got that generalized inhibition on the closed icosahedron of the ligaments. Then turn them over, strip down the rhomboids, strip across the teres minor and supraspinatus groove as well. Now, sit up, Paul, please. When you get to the supraspinatus, Let's see what it shows on here. It doesn't show anything on there. That's not going to help us. What have we got on here? Supraspinatus doesn't really show us much there. What you've got is the upper trapezius here and the supraspinatus here. Probably shown best on just the scapula. That's your supraspinatus groove. So your supraspinatus muscle is sitting in there. Now, also there's a nerve goes along there, comes down the arm, and what they'll do is they'll put steroid injections into this area here for bursitis and all sorts of things. And what you need to do is to get that supraspinatus working properly again and get them to glide. So you need to come on that supraspinatus border and go as far into there as possible and inhibit with your ligaments and make the arm go through the range of motion that will be the supraspinatus. So I'm inhibiting the ligaments and making it glide. And you find that starts to free off the restrictions in that area as well. Supraspinatus can cause a lot of problems. And as I pointed out earlier, it's the range of motion for the first 20 degrees that's going to pick up on your supraspinatus. So if you can't move your arm like that very easily, that's going to be the supraspinatus.